Thanks, Pino. Good afternoon, dear friends. It's a pleasure to be here. My name is Romualdo, and this section is quite exciting, I guess. We are going to talk about genetic assessment. Everybody knows or remember genetic assessing done with the fish technique in the 80s. Then we have seen a great evolution. Now we moved to the blastocyst biopsy, or even the blastocyst taking from the blastocell. So it's an honor to introduce Raul Orvieto, which is a full professor of Bengai in Tel Aviv University in Israel. He's a director of the reproductive endocrinology and fertility unit as well at the Seba Medical Center in Israel. He's a president of Israeli Fertility Association. He's a co-editor-in-chief of the journal Reproductive Biology and Endocrinology. He's a world leader known, has published hundreds of articles and many as well on the genetic assessment. So thanks very much, Raul, for your talk.
Chairman, ladies and gentlemen, thanks for that introduction. I would like to thank Dr. Kolpi and Karopo for the invitation. It is always a great pleasure for me to be back personally in Italy. So this is the title of my presentation. I have nothing to disclose. So every presentation of PGA should start with this slide showing that when women age increase, there is a decrease in live birth rate with an increase in miscarriage rate. And the increase in miscarriage rate is actually correspond or is same as the increase in embryo aneuploidy rate. So if we can identify euploid embryos in patients over the age of 35, meaning the advanced reproductive age patient, and transfer only the euploid embryo, we might increase live birth rate and reduce miscarriage rate. And this is actually what stands behind what we call first generation PGS, blastomer biopsy at day 3, fish analysis of 5, 6, 8 chromosomes, and transferring the euploid embryo. And then RCT appeared and meta-analysis, actually showing that first generation PGS didn't deliver. Not only that it didn't improve live birth rate in different fertility indication, advanced maternal age, repeat implantation, it actually impaired IVF outcome. So first generation PGS, out. And then this study appeared, a very interesting study by Scott, showing they are transferred two day 3 embryo to blastocysts. One of them underwent biopsy. They transferred these embryos, and then they took a buccal smear from the neonate and looked at matching. They knew which embryo was implanted. And as you can see, they showed that there is a 39% relative reduction in ongoing pregnancy rate when you are taking a biopsy from day 3 embryo, meaning that day 3 biopsy is detrimental. And I'm asking, is it? You can see that the ongoing pregnancy rate of the control group without biopsy is actually comparable to blastocyst stage transfer. So it's not that there is a reduction. There is actually an unexpected, incredible high ongoing pregnancy rate of the control day 3 embryo, because we are expecting, when you are transferring day 3 or day 5, and this is a CDC result, day 3 is always lower than 5. And in this study by Scott, day 3 and day 5 has the same ongoing pregnancy rate. So there's something wrong with this study. But let's assume that they are right. There is a detrimental effect of day 3 biopsy, and there is higher implantation rate when you are transferring a blastocyst stage embryo, and today, or that day, with all the new genetic platform and the ability to look at all the chromosome composition of the embryo, not only on 6 or 8 chromosome. So if we'll take a 2-factor biopsy from a blastocyst, transfer only the euploid blastocyst, so that will be a win-win situation. And this is actually what we call second generation PGS, euploid or other, dichotomic results, normal or abnormal, and then a lot of RCT appears, meta-analysis, of course, showing that transferring an euploid blastocyst results in significantly higher ongoing pregnancy compared to untested blastocyst. Nobody is arguing about this fact. If you have a euploid blastocyst, you transfer it, better results. The problem with these studies that if you're looking at the patients that were included, all these patients were good or best prognosis patients with at least 2 blastocysts, some of them with average of 8 blastocysts. In my clinic, 8 blastocysts is something that we are seeing maybe once a week. And they report pregnancy rate per transfer and not per started cycle. So in order to PGS or PGTA to deliver, it should actually fulfill several assumptions. And the most important one is whether the test is accurate and precise. What's accuracy and precision? Accuracy meaning that the test result is very close to the true value, and precision means that if you're doing a repeated measurement, you will get the same results. And this is the first study published on using NGS on several trough ectoderm biopsy from the same embryo, 8 embryos, all of them underwent 3 trough ectoderm biopsy, and 4 of them underwent also inner cell mass. And you can see here that 30% of the results were actually inconclusive or mosaic. And if you're looking at this embryo, which abnormal chaotic inner cell mass, if you took a biopsy from this area, it would be normal. You will transfer an embryo with chaotic embryo. And then other studies appeared in the literature, and this is a Canadian study. They took 37 abnormal embryos. Remember, in that days it was normal or abnormal. 37 abnormal embryo at the first test. Instead of discarding them, they towed them, took another biopsy, sent to another test. And look what's happened. 33% of this embryo in a different biopsy appeared normal. Mosaicism. Same study from Gleicher group, 11 embryo. They took several biopsies from the 11 abnormal embryo. They towed them, took several biopsies, sent them to different laboratories so they can look at the inter-laboratory, intra-laboratory congruity. And again, 36% of them were normal in the second trough ectoderm biopsy. And an intra-embryo analysis showed 50% difference in biopsy sites. In this study, they also had some embryo that in the first biopsy they were female, and the second biopsy they became male. So it's actually a kind of startup. So I'm showing you by these studies that repeated trough ectoderm or several trough ectoderm biopsy from the same embryo give different results, meaning that the test is not precise. How can you improve precision? So this is a study by Gleicher group, Rockefeller mathematician, using this equation. I can't understand the equation, but they showed that if you want that the biopsy will reflect the whole trough ectoderm cell, the 200 trough ectoderm cell, you need to take a 27 cell in your biopsy, not 5, 27. What is the problem with taking 27 cells in the biopsy? Same result like the day 3 biopsy. This is studies also from Scotch group showing that there is an inverse correlation between the amount of DNA, or the number of trough ectoderm cell, and ongoing implantation rate. More cell, more DNA, lower implantation rate. Detrimental effect on implantation rate also of blastocyst biopsy. What about accuracy? So again, normal, abnormal, and this is the study, famous study by Greco and by Gleicher, showing that if they are transferring mosaic embryo, they can still yield a normal neonate. Okay, so it's a kind of false positive. And then, since the study, physicians started to transfer abnormal embryo. At that day, it was dichotomic, normal, abnormal, and a lot of paper appeared, and actually a lot of criticism regarding the second generation PGS. And then in 2016, PGT, International Society, came into the play, and they tried to overcome this criticism. And in this position statement, 2016, they actually recommend not using anymore all this CGH test or in-house genetic platform, only validated NGS test. They also suggested that from now on, you're not saying normal, abnormal, but you are reporting cutoff points. they assume that there is 5 cells, so one cell, abnormal one cell, up to 20% mosaicism, it's normal. 20 to 80% is mosaic, euploid, aneuploid, and more than 80%, that's aneuploid embryo, should not be transferred. Why did they define this cutoff? Based on what? Expert opinion, okay? So this is the third generation PGS, and this expert opinion, 5 years later, this is a study by Capalbo. This is a non-selection clinical trial. They transfer embryo, euploid embryo, up to 20% mosaicism, low-grade mosaicism, 20 to 30% mosaic embryo, and moderate, medium-grade mosaicism, 30 to 50% aneuploid cell. So this is a no-selection study, and when they look at the outcome, so you can see that the live birth rate in all this group, up to 20%, 20 to 30, and 30 to 50, up to 50%, same. So it's again, up to 50% normal, more than 50% abnormal. Back to dichotomic result. And only another thing that I want you to pay attention is the miscarriage rate. Same in all over the group. So all the proponent of PGTA that's saying that it reduced miscarriage rate, where? Nada. Same miscarriage rate, 10%. And then many other studies on this new third generation PGS with 30, 40%. So this is Monet's study. Regardless the type of mosaicism, regardless the degree of mosaicism, if you're transferring mosaic embryo, at the end of the day, we'll get 30, 40% normal live birth rate. So why to test for? There's a lot of false positive, also in the third generation. This is a very nice study coming for NYU, Griffo Group. The reproducibility of troph ectoderm biopsy in euploid, and they showed this very long table. And in this table, they showed that in this first embryo, this is the first troph ectoderm results. They tore this embryo and took an inner cell mass and a troph ectoderm biopsy, and this is the result of the second troph ectoderm biopsy and the inner cell mass. And this is another embryo. This is a table. I only enlarged the table. This is the first troph ectoderm result, and they took 4 more biopsies, 2 from the inner cell mass and 2 from the troph ectoderm. And following this study, they showed that actually the PGTA is with high degree of accuracy and highly reliable. And I'm asking you, is it? So I decided to present their data not in this many letters and the numbers, but, you know, like the Italian, Picasso. Not Italian, but Picasso. So every line is one embryo. Every column is different biopsy. And every color is a different result of the biopsy. Now look at embryo number 19. The first troph ectoderm biopsy is yellow. The second, yellow. The third, different. The fourth, different. The inner cell mass, different. The second inner cell mass, different. So this is accurate and precise. In my opinion, it's a chaos. So that's what you are doing when you're taking several biopsies from the same embryo. What about false negative? So this is another study from New York. They transfer euploid embryo to a patient. She conceived, and then she miscarried. How come? So they took the DNA, the original DNA, and applied another test, and you can see what's the results. Euploid embryo that were transferred, conceived, and miscarried. 30% of them were mosaic, 2% were triploid. First biopsy, normal embryo, euploid, okay? So there is also some degree of false negative. The degree of false negative is very low. The degree of false positive, very high. So actually, you're offering a test that is not precise and not accurate. So why to offer such a test? If it was a glucose test and you had to inject insulin according to this result, I'm sure that nobody will adopt this test. Now let's go to real-world practice. This is a study from Cornell. They looked at their data, 2016. normal, abnormal, and they stratified the data according to the patient age. Up to 37, this is up to 37, there was no difference in ongoing pregnancy rate between those that underwent PGT and those that didn't. But we are not expecting a difference because, as I showed you in the first slide, if PGT-A will deliver, it should be delivered in the elderly patient. In an elderly patient, older than 37, it's delivered. If you're transferring euploid blastocysts in elderly patient, the pregnancy rate will be higher than transferring an untested blastocyst. But this is not the question. The question is for intention to treat. And they did this analysis. So in Cornell, 190 patients were embarked, 191 patients were embarked on PGT-A. Of this patient, 26 had no blastocysts. In my center, from this patient, I believe that 40 will not have any blastocysts. Those that, and the rest underwent PGT-A. Of those that underwent PGT-A, 105 couples out of the 191 had no single euploid blastocyst for transfer. No single one. Only 60 couples had euploid blastocyst for transfer, and from this patient, only 21 conceived and delivered. So actually, the pregnancy rate per started cycle was 41 out of 191. This was 21%. And this is the figure that you should present to your patient when you're counseling regarding PGT. But what's happened in the state? They are presenting this figure. This is the marketing figure because they show that 41 patients delivered out of 61 transfer. They forgot that 130 patients actually didn't get to the transfer stage. And then the STAR study appeared. Everybody waited for this RCT. Again, the problem with this RCT was the inclusion criteria, patient up to the age of 40, good prognosis patient, 7 blastocysts for average. So it's not the elderly patient. And when they analyzed the data, PGT-A versus non-PGT-A, no difference. And then they started to torch the data. And they stratified the data according to patient age up to 37 and above. Why 37, not 30, and why, sorry, up to 35 and above. Why 35 and not 37? Probably 35 fits their wishes, and 37 not. And then they showed that above 37, above 35, patient may benefit from PGT-A. Below 35, as we expected, no benefit. And again, looked at the miscarriage rate all over the groups. No difference in miscarriage rate with and without PGT-A. So again, PGT-A, according to these studies, does not reduce miscarriage rate. Now look at this flow chart. It's a very interesting flow chart, how they include and exclude patient. And you can see that many patients were excluded without any justification. Why to exclude patients that didn't reach didn't have 2 blastocysts? Why to exclude patients that didn't have any euploid blastocysts to transfer? Why to exclude patients that their blastocyst did not survive thawing? Because PGT-A you have to freeze and thaw. Otherwise you can transfer a fresh shade. So why to exclude this patient? You shouldn't. You have to bring all this exclusion back to the denominator, and the denominator is now no more 300, it should be 405 and 400. This is the true denominator. And if you reanalyze the data according to the true denominator, so again, when you look into all the patients, no difference, and when you look at the patient above 35 years, again, no difference. And this is, so also PGT-A third generation doesn't deliver, and this is also the Chinese study published in the New England Journal of Medicine, 600 patients in each group, first IVF, again, patient with at least 3 good quality embryo, no difference. So the real RCTs, looking at the intention to treat, show no difference. And this is the study of the year. This is a Turkish study. And the title is what? To advise a patient with only 1 good quality blastocyst, to PGT-A or not. So I believe that everybody, if you have only 1 embryo, you have to transfer, not to try to select what from what. So they have almost 1,000 couples in each group, and you can see the results. The PGT-A group This couple had 225 couples had euploid blastocysts. They transferred these blastocysts, and half of them, 51%, conceived, delivered. So 50% of the patient that with one blastocyst that underwent PGTA, 50% of those that underwent transfer, delivered. And of this, the patient that underwent untested blastocyst transfer, only 29% delivered. So what is the conclusion of this study? PGTA in the presence of a single blastocyst increases clinical pregnancy and live birth and decreases total pregnancy loss. It's amazing. I called Albertini, which is the editor of JAG, and I tell you, how come? How come this paper was published in your journal? So he said, went unnoticed. So look, 1,160 patients paid and underwent PGTA. Of them 115 delivered, so it's 10% live birth rate. And those that were underwent an untested blastocyst, 29%. So meaning that those patients that had only one blastocyst and paid 200, let's say, of these patients that paid for the PGTA, lost their only chance to deliver, because their blastocyst was found to be abnormal and was discarded instead of transferring and getting another 200 babies. Look, untested 30%, tested only 10%. There's the issue of time to pregnancy. Also the proponents say that if you do PGTA, time will be shortened. So let's use the ongoing pregnancy rate that was published by Dadu in the first meta-analysis, 65% for euploid blastocysts, 47% for untested blastocysts. After the first pickup, the one who underwent a transfer of untested, 47 will be pregnant, and those that are going to the PGTA, 0, because biopsy and cryopreservation. Second month, fresh FET, 65% of the euploid blastocysts will be pregnant, and here again, another 47, so again, 72 will be pregnant. And only in the third month of cycle, they will have a comparable. So there is no shortening of the time to pregnancy. So according to this data, I believe that have we reached the dead end? I believe that yes. And I believe that there are very limited clinical indication for PGTA. I believe, that's my opinion all over the years, but nowadays more and more. And only to almost conclude, this is a study, this is the practice committee of the SRM. It was published this month, this issue. This issue of fertility sterility, practice committee of the SRM. And the conclusion is the value of PGTAs as a routine screening test for all patients undergoing has not been demonstrated. Recent multi-center randomized trial in women with available blastocysts concluded that the overall outcome via frozen were similar. Good prognosis patient. The value of PGTA to lower the risk of clinical miscarriage is also unclear. I wrote a letter to the editor on a practice committee. I believe that there is no letter to the editor of practice committee, but they accepted and published my letter. And the practice committee replied. And this is the reply of the practice committee on behalf of the ASRA practice committee to my letter. And they are writing that we agree with the limitation of the studies referenced in the committee. So there is limitation. And more importantly, we agree that it is troubling that the use of PGTA in the United States is increasing despite the lack of evidence support this practice. I'm not surprised. Mio padre sempre ha detto, quando ci sono tanti dindini, allora si deve... This is probably one of the cases. And in the States, you know, they are offering also PGTA to donors, 25 years donors. Despite all these studies, they are still offering PGTA. And if you don't want to do PGTA, you can go to another center. And if I have 5 more minutes or 3 more minutes, I want to go to the basic science. I am allowed, okay. So why? I'm asking why. So everything is, you can see it in the real embryology. See, this is a very important study by the group of Magdalena Zernica. They created this mosaic embryo, haploid, aneuploid embryo using reservine. So you can see here embryo with several degrees of mosaicism. Mice embryo, not human. When they transfer this embryo with 50 or more percent euploid blastomer to the mice, all of them were implanted, normal pups. When they transfer embryos with less than 50% euploid blastomer, some of them implanted, normal pups. When all of the blastomer were aneuploid, no implantation, no pups. They also followed or monitored this embryo under time lapse. Yes, after staining the euploid and aneuploid cells, and they could see that during development, the aneuploid cells in the inner cell mass went to atresia, disappeared, self-correction, while the aneuploid cell in the trophectoderm remained, survive, and beat. Meaning that you are taking a biopsy from a trophectoderm with this abnormal cell that survive, while the inner cell mass is normal, corrected, okay? All the abnormal cells actually undergo apoptosis. So the embryo is normal, the trophectoderm is abnormal. So we're taking biopsy from one place which does not reflect the real things. And this is mice embryo. What's about human embryo? So look at this very nice time-lapse film. This is a human embryo. You can see that upon the first division, he excluded one cell out of the zona. 2 embryos were developed, 2 blastocysts were developed. The embryologist saw this and did not discard this embryo, but separate these 2 blastocysts, send them to genetic analysis. Okay? And upon genetic analysis, you can see that haplotyping these embryos, identical twins. But when you CGH these embryos, the embryo within the zona was euploid embryo, and the embryo that developed outside the zona was chaotic, meaning that the human embryo is very clever, because upon the first division, he identified an abnormal cell and expelled it outside the zona. And this is, again, human embryo. And you can see in this human embryo that following compaction, these embryos are expelling cell, vomiting cell outside the compaction. You see, they are vomiting, expelling cell. See here, you see? This embryo expelling cell. And we look at 112 embryos, so we see that 64% of this embryo, of human embryo, expel cells. What does it mean? So this is how it looks like after the embryo etched. You have a blastocyst and all the expelled cell within the zona. So we decide to examine this expelled cell and the blastocysts. And here is 11 blastocysts. 9 of them were euploid. We took all the blastocysts, not orvector, all the blastocysts. 9 of them were euploid, 2 of them were aneuploid. And this is the expelled cell. So of the 9 euploid blastocysts, 9 had normal euploid expelled cell or debris. But the other 5 have abnormal expelled or debris, meaning that the embryo identified this abnormal cell and expelled them. Now the embryo is euploid, but the expelled cells are aneuploid. In this abnormal embryo, the expelled cell had the same meiotic abnormality with an additional mitotic abnormality, and he identified and expelled it. Apropos, if you are now the 4th generation PGS, I'm not getting into it, it's the non-invasive. Excellent. You know where the DNA in the culture media comes from? The expelled cell. So you are taking the DNA that the embryo expelled in order to correct himself, and you say if the embryo is normal or abnormal. Okay, nothing to add. Thank you.
Thank you. Thanks very much, Raul, for your excellent talk. And I think we are now open for a hot debate, I would say. And so, therefore, I will call the discussant, Lodovico Parmigiani, and Paola Vigano and Quintero. Probably we can join the table. There is place for everybody, I guess. Yes, okay. So, okay, good. So, lady first, I guess. So, no, lady was gone. Okay. Have a seat.
Chairman, ladies and gentlemen, first, thank you very much for the invitation to Procrea, or not, because it's a very, very controversial round table. But it's clear in the controversial in medicine is the best way to reach the goal and the results. If put the second, how change the slides? Another slide. Where?
In bio,
Where? Oh. Sorry, okay. Okay. First, the presence of an euploidy is likely to result in implantation failure. This is maybe it's clear, or spontaneous abortion. Thus, PGT with next generation sequencing may improve embryo selection. At least this is the idea. But this is not. But is this true or not? From whom does PGTA have a greater beneficial impact? At the moment, there is not answer this question, at least not in total way. And that is why today we are here to answer this kind of doubts, because we don't have absolute conclusion, at least for the moment. I totally agree with Raul Orvieto. You present this paper. It's clear. The value of PGTA as routine screening for all patients, I don't agree with this. Don't being demonstrated. I would say that it's proven in patients under 37 years old. It's not used unless there is some indication other than screening. I would recommend it. I wouldn't recommend it. However, I would like to comment that there are studies, which everybody knows, in which PGT has been carried out in embryos development from donor oocytes in egg donation programs, in which aneuploidy has been observed in around 30% of the embryos. Some paper publishing these numbers. And it's a constant in the different studies with egg donation. I want to make it clear, don't exist any clinical criterion to indicate PGTAs in this kind of programs. But sometimes the patients demand this, and this is a problem for us. Raul say, I'm in another center, not in my center. I don't know if this is a good answer, but it's not bad answer. But it's clear, under 30 years old, it's not indicated the use of PGT. In contrast, there are very interesting and well-designed another research than this, for example, in patients over 38 years old. Maybe offer benefits compared to traditional IVF, demonstrating around the double live birth rates in this group of the patient with PGTA. It's very important to understand that this would be patient could be benefit for the use of PGT, decreasing the dropout, avoiding the patient that the bad experience of miscarriage, which is almost always experienced worse than negative pregnancy test, and avoided abnormal embryo transfers that we would not otherwise be able to recognize. So, it's important to take into account papers than this, like this, maybe with, it's different, a positive pregnancy test, positive clinical pregnancy. But it's clear when you transfer an unemployed embryo, in the most of the cases, you don't have a newborn. It's very important to remember the history and learn from the past. Being careful not to repeat the same mistakes. For example, a biopsy on day 3 followed by fish showed promising results at the beginning, but a serious, randomized, controlled trials revealed that the process was detrimental to live birth outcome. But let us not be paralyzed by fear for past mistake, but always move toward the future with an open mind. It's clear we need more trials to obtain conclusive answers for the use of PGT.
No, 2 slides. Only 2. Can I have my slide? Okay. In total support of Professor Orvieto, I would like to focus a little bit on the recent opinion paper of the ESRM committee. Because I think that everybody can recognize the scientific rigor of the SRM. The SRM committee has provided a lot of recommendations all over the year in several strategies of ART. And in this volume, in the present volume, in September, now they have published this opinion paper on PGTA. So I would suggest to read this opinion paper because it's very clear, but because what they did is to consider a lot of topics from PGTA, and they did a single paragraph for each of the topic, and at the end of each paragraph they provided a conclusion. So today I'm going to present to you the conclusion of this opinion paper, and I put in orange the evidence that are controversial, in green the one in which they consider the possibility to use PGTA, and in red the recommendation against the use of PGTA, or where there are no evidence at all. So for favorable prognosis patient, they mentioned that some earlier single-center study reported high birth rates after PGTA and a single embryo transfer in the primary embryo transfer of favorable prognosis patient, but 2 recent multi-center randomized controlled trials in women with available blastocysts concluded that overall pregnancy outcome via frozen embryo transfer was similar between conventional IVF and PGTA. For advanced maternal age, it's the only indication that they were positive. They mentioned that the PGTA may have a beneficial role in patients on advanced maternal age, especially those with good ovarian reserve. For use of donor cycles, the totality of evidence argues against the routine use of PGTA in donor egg cycle. For advanced maternal age, the available evidence suggests that routine PGTA testing should not be performed for advanced maternal age. For recurrent pregnancy loss, very important, today definitive evidence on the benefit of PGTA in this patient population is lacking. For the use of PGTA together with PGTM, which is a very hot topic, they mention that further study on the use of PGTA in the setting of PGTM are needed in this population, and the counseling needs to be individualized. For male factors infertility, PGTA should not be used for this purpose only. The evidence is insufficient to make recommendation for cases when testicular sperm is used, and more studies are needed. For a cost effectiveness, more research is needed. For mosaicism, another hot topic, the data suggest the need for additional investigation of the validity and accuracy of a mosaic diagnosis. For accuracy, we have already heard from Professor Orvieto, because new technology evolves, which allowed for diagnosis such as mosaicism, segmental duplication, and deletion, it will be important to understand the reproductive potential of embryo assigned as a result before widespread utilization. For embryo damage, the impact of biopsy of the trophectoderm is not well understood, and given the importance of the trophectoderm for implantation, damage to the trophectoderm may impact this clinical event. They recognize that there are gaps in knowledge, so they, first of all, one of the gaps is the time to pregnancy. There is the need for increased research in the lab for doing PGTA, and so this is another gap in knowledge. We don't know about the self-correction and false positive results. We don't have the entire picture. And we have this problem of the variation in aneuploidy rates between laboratories, and we have heard from Professor Orvieto. And their conclusion is overall that at present, however, the routine use of blastocyst biopsy with aneuploidy testing in all infertile patients undergoing IVF treatment cannot be recommended. And so if we all recognize the scientific rigor of ESRM, considering to go against this recommendation means that we have other reasons to not respect this recommendation from a scientific point of view. Thank you.
I think Lodo is going to add some other comment. In the meantime, from the audience, if someone want to reply later on or want to add any comment, please feel free to come to the microphone.
Do we have any question? No. Yeah.
So, thank you for the nice presentation. And having done most literature on PGTA recently, I want to stress on because scientifically, ASRM as any other, if you could put that last slide with the 4 lines. So ASRM has the same problem as any society, because the START trial that was done in the US, which included all centers around the US, actually was a big mess, and they could not achieve any conclusion about PGTA, therefore the committee opinion. If you look at what you said in terms of gaps in knowledge, everything is about the resources we have. So the second one, the need for increased resources in the lab, self-correction that we don't understand, and also variation in lab results. Everything is our way of doing PGTA. It's not PGTA itself which is the cause. Yes, I agree. So I think scientifically PGTA can offer us an improvement in the ART, provided it is done correctly. The problem is that, for example, it's very nice to say there are 2 multicentric randomized trials, whereas we actually wrote a paper in Human Reproduction because New England doesn't take a letter to the editors, where we explain why there is limitation into understanding PGTA in an RCT. That RCT has nothing to do with an RCT. It's just that they're randomized, but the groups were completely incorrectly managed. And therefore, their conclusions are misleading, but actually they achieve something great. That, of course, it's very difficult to acknowledge, is that biopsy is very safe. If you go back and you get to the New England paper and you look into the data, you actually see that their outcomes show that the biopsy is quite safe, but it's indirectly, it's not directly. This is what they wanted to show. And I think it's very important that to acknowledge that even the US, which is the size of Europe, they have the same debates we have here today. And therefore, they will say no, they want to say yes. The reality is that you cannot deny the time to pregnancy that PGT offers.
Yes.
I mean, we have to acknowledge that miscarriages, complications from miscarriages, emotional stress, dropout, this is something which is incrementally diminished in PGTA use. And I think the problem is that so far, not many patients have actually validated their test of PGTA in a correct manner. We use Cooper projects, Fisher, whatever. None of those tests have been validated for predictive and negative values. And each time they come with an update, it's based on the first one, which was not actually tested. And this is where the problem lies. It's not about the scientific value of PGTA, it's how we deploy it in our patients. Thank you.
Yes, I don't know. Okay, go on. I need to say.
2 comments. First of all, time to pregnancy. I show the slide.
Microphone, please.
Time to pregnancy. I show a slide. Nicely, logical, mathematics, second class. PGTA doesn't shorten the time to pregnancy. Yeah, because after the first pickup, 50% of the patients that underwent untested blastocyst transfer will be pregnant. And those that underwent PGTA will not be pregnant because the embryo are biopsied and cryopreserved, so they have to wait another month, right? In the other months, the one that were not pregnant in the untested blastocyst transfer will get another embryo transfer. And 47% of them will be also, so only after 3 months they will get the same. So it doesn't shorten. And about miscarriage rate, all the RCTs show that there is no difference in miscarriage rate. Capalbo study, the non-selection, no difference in miscarriage rate. Probably the invest maternal age. And invest maternal age is the only, maybe, but only in very good prognosis patients who are expecting 4 or 5 blastocysts. Otherwise, don't do it because you will not get a blastocyst, you will not get an euploid blastocyst because 90% of blastocysts in advanced maternal will be aneuploid according to the test. And you will not transfer them. And another thing that you should realize that PGTA is not a treatment. It is not a treatment. It's not a treatment. You don't give optalgin or paracetamol to the patient, to the embryo. That's the embryo.
May I comment a little bit? It's fine, but every time that you speak with a person who is a pro-PGTA, what the people do is move from the biological side to the social side, psychological side, economic side. But the problem of the technique now, I agree, maybe it will be, it's the accuracy. It's not an accurate procedure. Dr. Orvieto is right. If you use insulin, nobody will take it. So the first problem is that now the technology is not accurate. And then we could talk about other aspects.
Just a comment, please. I am an andrologist, so I am not an expert in this topic, but I am interested clearly for obvious reason. May I have the first slide of Professor Vigano? Well, there was an indication that is advanced maternal age with a good reserve ovarian. Okay, but I want to know, what do you mean for good ovarian reserve? That is, if you obtain many blastocysts PGT is maybe be indicated, and in the case you have a few blastocysts or one blastocyst, no. What is the cutoff? Because Professor Orvieto just a few minutes ago said, okay, if you have only one blastocyst, will you perform a PGT? Okay, or if you have only two blastocysts, will you perform? So I would, because I am interested, not for the normal cycles, but clearly I operate on non-obstructive azoospermia patients. I obtain some difficulty sperm in many cases, and I have to use this sperm, and I use also fresh sperm with an incredible difficulty of organization difficulties, okay, to obtain fertilization and so blastocysts, and then if the woman is 38-year-old, and we obtain one or two blastocysts, what can we do? What must we do? I would hear the expert opinions.
In my opinion, Prof. Colpi, in this group of the patient, in my point of view, it's very important to do the PGT in 1, 2, or 3 blastocysts, because I think it's better, don't transfer, than transfer 1 blastocyst and after the patient of 40 years old finishing miscarriage, malformation, etc. What is better for a patient?
Well, really, I don't understand, because we cannot obtain so many blastocysts generally,
Normally.
particularly in a 38, 39, 41-year-old woman.
Yeah.
So I obtain 1 blastocyst, which is very precious, okay, or 2 blastocysts, okay. And what must I do? That is, Professor Orvieto, what should I do?
Listen, they're speaking
Fresh blood.
transfer. Don't do PGT.
That is
They're speaking about
that is the
SRM,
opinion of the SRM,
the
but
SRM,
I wouldn't do the PGTA in that case. I would transfer.
The SRM concluded that in advanced maternal age, they might benefit if they are good prognosis patient or with high ovarian reserve. You need at least 4 or 5 blastocysts in this age in order to get 1 euploid blastocyst, because we know that as maternal age increases, the aneuploid rate increases. It gets up to 70–80% in this age group. So you need 4 blastocysts at least in order to offer this advanced age patient a PGTA. To get 4 blastocysts, everybody, you should, as he said, different lab, every lab has its capability. But there is the Goldman study showing that to get 4 blastocysts in a patient over the age of 37, 38, you need 20 oocytes. So if you have an advanced maternal age patient with 20 oocytes, okay, offer the PGTA.
Really,
20 oocytes.
normal, I have not so many blastocysts.
Okay,
So
but-
transfer.
1 or 2, so transfer.
problem.
Yes.
So you should see what's the blastulation rate in your center. Then according to this, try to offer or not.
So I just want to rebound on Professor Orvieto's presentation that I liked very much, because I pretty much think exactly the same. I want to get back to one specific article on the SART results, SART outcomes, cumulative live birth outcomes in 2018 in the US. And we are talking here about the right denominator, which is cumulative live birth rate per started cycle. And when you look at these outcomes, they did 3 different groups: the hyper response patient, the normal response patients, and the lower response patients. And it was really clear that for lower response patients, the cumulative live birth rate, when you perform a fresh transfer, is higher. Not only is it higher, but if you don't do PGS, you just prove that you have also a better time to pregnancy. So we are talking about a test that is not really good, but sometimes useful, let's say it. But we have to talk about the ground, the soil of what we are doing. The patient context is the most important thing, as shown by the SART data. You double the live birth per oocyte pickup by doing a fresh transfer in the low response patient. That's outstanding, and that's exactly what you showed. And I think that we have to think about the context before the test. That's my opinion.
There is a study by Glacher that showed the live birth rate in the States since the beginning of adopting PGTA, it decreased. So live birth rate in the States is going down with the increasing use of PGTA.
Well, I guess Lodo want to talk now. Yeah, thank you.
Okay, thank you. I don't have slides. I bring just the opinion. I'm just an embryologist, okay? Despite I seem young, it is 30 years that I'm working in the lab. First of all, I have to thank Professor Orvieto because the presentation was fantastic. It is the classic example of having a theory and demonstrate this theory by analyzing the article and also dissecting the article. It was amazing. Also try to find what is wrong in the articles. So, well, I also appreciated the comment of the colleague, but I think that we are all agree that there is a problem in the accuracy of the technique, okay? And this because also in my career, we have performed several different techniques. We switched from, we have seen IVF and then ICSI, through freezing, vitrification. In the case of PGT, we have seen a different genetic way of analyzing the embryos. And I remember that when we restarted to do PGT in Italy, which was in 1997 probably, we switched to ES-FISH to CGHRH and then NGS with that moment with mosaicism, which was a terrible moment. And then at the end we found this agreement of asking to genetic lab to call black or white. But when I started my job, it was 1994 in the lab, and somebody told me that in the future you will have 100% of survival with blastocyst, survival after freezing. I never believed. The same. You will have 60% of pregnancy on your PGT patient, because I remember we were performing PGT in 1997 at the hospital in Bologna. It was so, and this is what we have in our lab, in our group of patients. And then, so what we are discussing now, we have some guidelines, and the guidelines say which are the category of patients were applying this technique. And we can discuss about it. It was fantastic, your example of fresh cycle, no? Because I was discussing with Paola and saying, okay, let's consider time of pregnancy. And then you said, no, if you go the fresh cycle, okay. If you cannot do the fresh cycle, if you cannot do it.
Can do it because she's high responder at risk to develop OHSS.
Or
this is the patient that
she don't have a good endometrium. So I'm an embryologist, okay?
So I said limited indication.
Okay.
And very limited indication.
Okay.
If.
Okay.
Okay.
And then again,
not universal use, because what's
Not
happening in the
universal
States,
use.
that 60 or 70% of the
okay.
of
I'm
centers
just
doing
thinking to fix some point to wrap up this meeting, okay? And the last is regarding money. Wonderful. You also said in Italian. Yes, correct. If we can demonstrate that we have the same efficiency in some category of patient, it is just deciding where the money are going, to genetic lab or to the doctors doing the transfer, okay? It is not...
The issue is how much the patient is paying, not how much the doctor.
the patient, in the real world, the patients can pay the same for a transfer, for an embryo transfer, for PGT of 4 embryos. Let's consider 4 embryo transfers and the PGT for 4 embryos. I do this every time in the lab with our patients. So it is just a problem.
It's not how much the doctors...
Which is gaining the money,
it's not
the
how much
doctors or the lab?
I think that how much the patient is paying. You know, in Israel, they are doing PGTA, very small numbers.
Okay, you got the
But
example of
you pay
Israel.
600,
So this is not worldwide.
Okay, you are paying 600 euro for an embryo biopsy.
In Europe, it's
Otherwise,
less.
you pay nothing for IVF.
In Europe, it's less. It's less than 300.
You're paying a lot of money for PGTA. No, we have these gay couples that are doing PGTA and egg donation, no, surrogacy and egg donation in the States. Egg donation, 25 years old donors. If they won't pay to PGTA, they send them to another center. Because
this is a wrong use of PGTA because we already know that for egg donation we don't need PGTA. Because we know, Luis can tell to us that, with egg donation we have, 70. Okay.
Yes, but
I'm bringing my opinion here. So,
like Lodovico said, first in Spain, is the cost of PGTA is slower in this moment, but
maybe in Italy or in Spain, but not in
no, in Europe in general, than in other countries. But
I have a few questions, if I can.
Sorry, I'm convinced the problem is not the PGTA. The problem is the indication of the PGTA.
Okay.
The PGTA is a good tool.
I have a question about the accuracy of this testing. If we have a so really high false positive rate, in the same manner we should have a very high rate of false negative rates. We, since many years, we perform a cytogenetic test in all the spontaneous abortion in our patients. For the fresh cycle, for the frozen ones, and for the PGTA and non-PGTA. In the abortion from the PGTA, until now we had no abnormal chromosome.
Yeah, correct.
Then that is why, if you have so high positive rate, you should have exactly the same rate of negative, false positive. But in the clinical practice, if you perform a chromosomical test of the abortion, we never had one abnormal test. Yeah. Then what's on? And if you have, for me, we perform only few PGTA. Is the indication as advanced maternal age with good ovarian reserve, in which you usually go to a strong induction to have many ovocytes, because older patients need more ovocytes than younger. And in many cases, you had to perform a freeze-all. You had 3 to 4 blastocysts, and you freeze them all because you are aware of the very high risk of hyperstimulation. Then the type of pregnancy is exactly the same. But in older age patients, we have from 40 to 43 and 44, from the 40 to 70% abortions. And when a woman had a spontaneous abortion or an abnormal chromosome embryo, she will never perform another transfer without knowing is euploid or not.
Excellent.
Never.
Absolutely.
It's my small opinion and questions. in the clinical practice.
Well, let's load. Do you want to reply, or do you?
No, because I totally agree.
Totally agree.
No, that's why the SRM probably said that for advanced maternal age, it's a good indication. Yes.
Well, I guess if I can add something which is quite relevant, and then maybe we are going to conclude the section because it's time. One important thing, in my opinion, is the counseling of the couple. Because, I mean, we talk about, as Paola say, about the social issue, about financial issue, but we can spend the time to talk here, and we never found an agreement about financial. Because in Italy, IVF is a cost, in Switzerland is another cost, in UK is different, in US is different, in Israel is different, so it's difficult a lot to generalize.
But the time is the same.
No, talking about
worldwide.
financial, I'm saying. What I think is important when you address a PGDS, genetic assessing cycle, the couple should be informed basically from the cost, from the beginning, and as Professor Orvieto say, also in relation of the transfer, because it's easy to say you have the embryo transfer, I mean pregnancy on the embryo transfer, but if you have pregnancy from cycle started, so the number is completely different. And I think that's important to acknowledge this and to inform to the patient. Professor Colpi, yes?
No.
Let's conclude.
Yes. May I have, no, please, Pablo. No, you. Do you want to add something?
Only one thing about money. In our region, that is Lombardy region, in which we can perform PGTA, and the patient pays only the PGTA, but all the rest is completely covered by the national insurance. Deciding to perform a PGTA in a couple for your center is knowing that you will lose a lot of money, because 40% of them will never have a transfer and perform a retrieval, a long blastocyst culture, a biopsy, and so on, knowing that 40% of the patient will not have embryo to transfer, is knowing that you will lose a lot of money.
But you will have a lot of babies in your cryo
A lot of
bank.
babies.
Yes, babies.
Babies. Because, in your opinion, Paula, all the blastocysts are babies.
Not babies.
Potential babies.
And USA worst opinion.
This is for the next Congress, okay?
Okay. May I add a conclusive comment?
Yeah.
Because, this morning we spoke about sperm DNA fragmentation. And the conclusion was, there is too low evidence. There is a low evidence to suggest sperm DNA fragmentation testing as a routine test for all the infertile couples. Okay. Well, really in my field, Schlegel at least says, when there is a low evidence, it is better to have low evidence than no evidence.
Yes.
Okay? Well, and so I wonder why, in this case, we cannot perform STF testing routinely, but we must wait at least 2 ICSI cycle failures to decide that, okay, it is better that you male perform a sperm DNA fragmentation. What is the cost of 2 ICSI cycle monetarily, psychologically, sanitary is nothing? Okay, this is the problem. Okay, now I refer again only to the kind of patients I treat regularly, that is non-obstructive azoospermic, okay? And I again say, well, if I find the sperm, and the sperm are used for ICSI, fresh ICSI, and I obtain, fortunately, 1-2 blastocysts. Also, if the woman is 38, 40-year-old, okay. I listen very carefully to all the speakers, okay? And there is no evidence in this case, this particular case, that I can have an advantage. Therefore, why should I test these kind of patients with PGTA? Okay, this is the problem. Because either you use the same method for both the situation, otherwise there is something different. It's not only a problem of cost. We are talking about the cost of PGTA, which is...
As an embryologist...
And what is the cost of X cycle performed without success if we realize later that the reason of the unsuccess probably was a very high sperm fragmentation index. So
I will add a very small argument, very small. What about day 3 versus day 5? Transferring day 3 versus day 5.
This is for the next Congress. So
this is for the next Congress, yes. There is a new study now in Nature Communication showing actually the same, everything that we know, the day 3, day 5, cumulative, same. And the problem is, if you should go to the blastocyst stage, it's only for selection and depends on your ability or capability in the lab. If your blastulation rate is high, so go. If low, don't go.
So,
to be truthful, I must add that we transfer regularly at 5 days, the 5th day, okay? And I pressed the laboratory and the medical team to perform transfer only at 5, because as an andrologist, I want to see if we will obtain blastocysts or not. This is the problem.
Well,
can I also make
last
short
comment,
comment and pray?
Last comment, and then we close.
Very short. I enjoyed this discussion. I had also things to say. I enjoyed it other times. But if I can be a little bit brutal, we are discussing on whether it is honest and ethical to invoice this test. Maybe I'm a dreamer, I'm a stupid scientist, but when I saw this tool, I said, okay, this is something we should use to investigate the mechanism and how to put remedy. And the same is true for DNA fragmentation. We are investing efforts, money, to validate the voice. We should readdress our research to understand the mechanism and to look for remedies. I am a little bit astonished that we should change our position a little bit.
I agree. So let's close this section. We'll come back tomorrow morning, 8:45. Thank you. Have a good evening.